Hello viewers, I am Dr. Shanthakumari, Assistant Professor from the Department of Public Health Dentistry, here to speak about the role of dentist in palliative care. In previous session, I have discussed on these topics. In this part of my presentation, I would like to talk about the significance of palliative care in the field of dentistry. As we all know, oral problems or diseases could happen due to poor oral hygiene, improper food intake. Treatments to specific diseases like malignant lesions would induce many problems or side effects to the bedridden patients. For such kind of patients, the oral problems could be directly related or indirectly related to, or could be a combination of many factors. For example, if the oral disease is involved anatomically, that will give a direct effect to the patient. If the disease affects physiologically, then the oral problem is indirectly related. So, in every situation, to maintain a good oral health, a dentist's role is considered to be a very important in palliative care team. Basically, for every individual, a clean and infection-free oral cavity is a basic need. In 1993, Heel stated that if a patient's oral status is good, then it is a good indication of the palliative care. Obviously, if an individual maintains a good oral care, that person's self-esteem, comfort, ability to communicate, socialization will improve. He will also enjoy the food and drinks. To achieve this, assessment before the treatment for oral problem has to be done. To plan this, we need to examine the patient thoroughly and assess for any oral conditions like ulceration, pain or tooth decay in the oral cavity. Then document these findings accurately and assess them often at periodic intervals. Now we will see the factors in deciding the management of the oral conditions. There are three types of management. One is definitive management, second one is symptomatic management, third one is management of the causative factor. We can choose definitive management if we have any chance of cure from the disease is expected. If not, then symptomatic management can be given as palliation therapy. In some instances, we can directly treat the causative factor of the disease itself. So, based on the extent of the disease, the management would be a local or a systemic one. Generally, all these factors are considered based on patient's general health condition and wishes of the patient. Now, let's move on to the type of oral care given to different oral conditions. First, let's see the denture hygiene. The patient who are a denture wearer at least once daily, preferably at night time, the denture has to be removed and cleaned. Removed dentures has to be cleaned by brushing and rinse it with water as well. To maintain a healthy oral mucosa, leave the denture out of the mouth overnight. We can also use salivary substitutes to lubricate the lips and mouth to avoid pain and irritation before replacing the denture in the mouth. Similarly, for dentulous patients, gently retract the cheek and brush their inner surfaces of the oral cavity with gentle strokes. Then, using a gauze, hold the tongue, gently brush it from rear to front direction. Then brush the palate also, and if airway is at risk, cautiously aspirate the oral cavity. The next common oral condition among the palliative patients is oral candidiasis. There are topical antifungal agents that are being used for managing oral candidiasis. Drug groups like Pauline group, example nystatin, amphotericin can be given. In azole group, clotrimoxazole and miconazole can be administered. Other topical agents like chlorhexidine, gentian violet, tea tree oil are recommended for oral candidiasis. Usually, these drugs are given for a course of 7 to 14 days, 4 times a day. Now, we will see certain salivary stimulants that are given in palliative care. The action of salivary stimulants is it increases the salivary flow by stimulating the chemoreceptor and mechanoreceptors that are present in and around the oral cavity respectively. Chewing gums, organic acids like ascorbic acid, citric acid and parasympathomimetic drugs like pilocarpine can be given as salivary stimulants. Though we use the organic acids as salivary stimulants, we have to use it very cautiously because sometimes it causes discomfort in patients with dry mucosa and it may also cause demineralization of teeth. Thus, it is contraindicated in dentulous patients. Now we will see the uses of salivary substitutes in oral conditions. Before that, let's see the difference between the salivary stimulants and salivary substitutes. Salivary stimulant is something that increases the natural production of saliva, whereas salivary substitute is a substance that are made similar to mucus secretions, which is normally produced in the human mouth. For example, water and artificial saliva are used as salivary substitutes. These are available in different forms like spray, gel, lozenges, etc. This can be applied during day and night time. Next, we will see the importance of nutrition in patients under palliative care. Usually, patients with terminal illness will be lacking in nutrition, which may significantly affect their quality of life. To balance this, we need to assess their nutritional status, particularly water and sodium needs that has to be maintained. In palliative care, the overall goal of nutritional support includes two things. First one is minimization of food related discomfort, because sometimes instead of giving pleasure, food may cause discomfort to the patient. Second nutritional goal is to ensure their food to be gentle to their gut, and overfeeding should be avoided because their digestion would be very minimal. Thus, following these principles in maintaining the nutrition among palliative care patients will reduce the tension and will make the patient a sense of well-being. Next one is wound care among the palliative patients. Typical wounds among palliative patients include pressure ulcers or bed sores, ischemic wounds, etc. It is indicated as dusky, erythematous and mottled discoloration. To manage such type of ulcers, early signs that indicate a skin breakdown should be assessed and monitored carefully. Sometimes this could happen due to chronic diseases, aging, comorbidities and side effects of treatments. However, palliative wound care for such patients is different from traditional wound care. In traditional wound care, wound closure and healing are the goals in wound management, whereas in modern palliative wound care, promoting comfort and dignity of the patient, relieving the suffering and improving the quality of life are considered to be the goals in wound management. Let's see the key components of wound care for palliative patients. First one is we have to reduce the risk that causes the skin breakdown and further damage. Second one is management of general symptoms like pain and pruritus. Third one is keeping a psychosocial well-being of the patient. Finally comes the local wound management. Now we will see the first component, the risk that causes the skin breakdown. Conditions like pressure ulcers for which regular repositioning and proper skin care has to be given. In accordance with the patient's wishes, this can be done at least every 4 hours once. At the same time, these turning and repositioning decisions has to be documented because sometimes premedicating the individual is needed who experience significant pain on movement. In that situation, premedication is given 20 to 30 minutes prior to your scheduled position change. Next is maintenance of skin care. Cleansing, hydrating and moisturizing the skin is inevitable and the caregiver has to be trained in practicing a good skin care. Now we will see the second component in wound care, that is management of general symptoms like wound associated pain and pruritus. As a general rule, analgesics, topical agents or dressings can be given at regular intervals until the pain is adequately relieved. Next problem is pruritus. When excessive washing and bathing is given to palliative patients, lipid from the skin surface will be stripped off, which induces the dryness and may lead to pruritus. To replace the lost lipid, skin moisturizer or lubricant should be used on a regular basis. Next component in wound care is psychosocial component. Maintaining psychosocial well-being for emotional distress is considered to be very important in palliative patients and their family members because it has an impact on quality of life. The last and final component in wound care is local wound care and symptom management such as trauma and bleeding. Even a minor trauma like removal of wound dressings will pull off the skin surface from the epithelium, which may lead to bleeding. So, To protect this peri-wound surfaces, wipes, sprays, gels and liquid roll-ons are useful. Next is management of odor from palliative patient. For this, metronidazole can be used as an anti-inflammatory and anti-infective agent. But when it comes to management of exudate in palliative patients, multidisciplinary approach is required. Let's move on to the pain management recommended by WHO. Pain is a common symptom in patients who have advanced and progressive diseases, which badly affects their quality of life. To manage this, WHO is recommending an approach called WHO analgesic ladder. This approach has given three main principles. They are by the clock, by the mouth, by the ladder principles. By the clock principle says to maintain freedom from pain, drugs should be given by the clock or around the clock rather than only on demand. This means drugs are given on a regularly scheduled basis without waiting for the onset of pain. Next is by the mouth principle. It describes about the route of drug administration. Usually, the oral route is the preferred route in various conditions. However, it may not be possible for all patients. For example, the patient in end-of-life situations, unconscious patients, patients who have swallowing issues where the oral route is not feasible, the least invasive route like sublingual or subcutaneous route is preferred. Next one is by the ladder principle. According to this principle, if pain occurs, prompt administration of drugs has to be given. If the patient have a mild to moderate pain, then the step 1 non-opioids like acetaminophen can be given. If the patient have a moderate to severe pain, then step 2 mild opioids like codeine can be given. Whereas in step 3 strong opioids like morphine or hydromorphine can be given until the patient is free of pain. Suppose when there is a severe pain, we can begin at the top of the ladder with a strong opioid, that is step 3. Once this pain is controlled, the pain should be maintained on that dose, which is very effective. We can also give adjuvants or additional drugs like antidepressants, anticonvulsants, corticosteroids and anxiolytics like diazepam along any step in the ladder. Thus, this three-step approach is considered to be an effective and inexpensive approach in pain management for palliative patients. Now, let's see the barriers to palliative care. Though the palliative care can improve the quality of life and reduces the stress, palliative care services are still not available to all patients. There are certain factors that are considered to be the barriers to palliative care. They are national health policies and health systems. These systems and policies often do not include palliative care as a part of services. Also, training on palliative care for health professionals is often limited. Next barrier is inadequate access to pain relieving drugs such as opioid drugs. Apart from this, there exists a lack of awareness among policymakers, health professionals and the public about what palliative care is. Furthermore, cultural and social barriers, misconceptions about palliative care. For example, some people may think palliative care is given only for patients with cancer or for the patients who are at the last weeks of their life. Also, there exists a misconceptions regarding the usage of opioid drugs. They misunderstand that increased usage of drugs will lead to substance abuse. All these factors are considered to be the barriers to the palliative care. So, to overcome such kind of barriers, we have to strengthen the above said factors to promote the palliative care system, for which we shall integrate the palliative care into all relevant disease control and health system plans. We have to develop guidelines and tools on integrated and comprehensive palliative care. Steps should be taken to improve access to palliative care medicines through improved national regulations and delivery systems. Along with this, people living with HIV also should be taken into consideration for palliative care. Focus has to be given on developing guidelines of palliative care for children, monitoring and evaluating palliative care programs as well. Also, adequate resources for palliative care programs and research building models of palliative care would be effective in strengthening the palliative care system. I conclude by saying palliative dental care would definitely help to relieve the pain and discomfort in patients with terminal illness and other ailments. With comprehensive palliative care, patients can maintain their oral health and they can enjoy eating, drinking and talking and can be kept more comfortably. I would like to stress that if your loved one is considering a palliative care with hospice or with their physicians, ask them to speak to their dentist about maintaining their oral health too. Now, let's make a real effort to achieve this goal. Thank you.